everyone. I'm Tom Davis, WDI Global Sector Lead for Health and Nutrition. This presentation today is about care groups and nurturing care groups. If you have not heard me present on care groups and nurturing care groups before, I assume you may be living under a rock or in Antarctica with a poor internet connection. Since a very small number of you may need some of the information on the description of the approach or on the evidence for the approach, please feel free to advance through the slides and info that you have already seen before. So the Nurturing Care Group's core project model is based on the decades of experience with the care group approach, and we're going to talk some now to give you a description of the model. This model is a community-based strategy for improving coverage and behavior change. The approach was developed initially by Dr. Peter Ernst with Rural Relief Mozambique, and in his acceptance speech for the Dory Storm's Child Survival Award, Peter mentioned that the idea for this model came to him from the advice that Jethro gave Moses in the Bible in Exodus 18:17, which I can imagine Jethro giving to a community health worker or one of our World Vision staff today. He said, "The work is too heavy for you. You cannot handle it alone," and he taught him how to delegate. Adunia and I were co-pioneers of that approach, applying it in a population of more than 1 million people in Mozambique beginning in 1997. The approach focuses on building teams of volunteer women who are selected by their peers, who then represent, serve, and do behavior promotion with both male and female caregivers in blocks of about 12 households each. And by using home visits, the volunteers are more likely to reach both men and women caregivers and to change gender norms. Nurturing care groups are simply World Vision's multi-sectoral version of the care group approach. They are what we call plug and play. They have already been used to promote many of the behaviors that we focus on in WASH, health, and nutrition, including maternal and newborn child health, HIV, TB, and malaria, sexual and reproductive health, and prevention and management of diseases such as cholera, Zika, chikungunya, dengue, Ebola, and COVID-19. And there are lessons already produced to do these, the promotion of behaviors around these diseases. I developed a program model based on this approach for use in promoting education behaviors that has had some great results in Tanzania, and we are testing it now for use with child protection and other protection behaviors in Ghana. Note that the volunteers used in this model are pure volunteers. They have a light workload, less than 8 hours a week, and usually closer to 4 to 6 hours, and they receive no monetary incentives whatsoever, just job aids. And despite that, we often see volunteer dropout rates of less than 5% per year. So what is actually done in this approach that has had some amazing results compared to traditional behavior change approaches? Well, when you see the results we found in both huge data sets with less rigorous research methodology and with smaller data sets with more rigorous research methodology, like some of the ones I'll be describing to you, and then hear the overall approach in simple terms, it sounds impossible. The overall approach is that you teach paid World Vision nurturing care group promoters or community health workers serving in that role or other group facilitators to teach volunteers how to promote behaviors from different sectors. And then you have those volunteers promote behavior change to caregivers of children. And then you just repeat that every 2 weeks. So that may sound like other models you've used, but there are some key differences between this approach and other approaches that make all the difference. Things like the way you set up the group size and composition, the coverage plan, how you select the volunteers, the meeting frequency, the lesson plan format, which has a lot of important behavior change lessons learned incorporated into that, and other elements. This is what the model looks like. So starting from the right, you're organizing households into groups of about 10 to 12. And then from that, you bring together the primary caregivers and ask them to select a volunteer amongst themselves or or it can be someone outside of their households, to serve as a volunteer that will serve those households. Then you bring together about 10 to 12 of those volunteers every 2 weeks into the care group or the nurturing care group. Nurturing care group if you're promoting a lot of different sectoral behaviors, and we just call it the care groups if they're only promoting things like health, nutrition, and WASH. Those, each promoter supervises about 5 to 9 of these nurturing care groups, these groups of volunteers. The promoters are then supervised themselves. And in a larger project, you often have a coordinator who is the supervisor of the care group supervisors himself when you have many of them. Now, these groups meet about every 2 weeks. And you can see up above there some of those numbers which are important in terms of group size. We try to never exceed those group sizes. But with that, each nurturing care group promoter reaches about 400 to 2,025 households. If you have a community health worker serving as a nurturing care group promoter, they reach only 2 groups, 1 to 2 groups of volunteers who then reach out to about 10 to 15 households each. This is what it looks like for comparing the Ministry of Health-led versus NGO-led care group structure. So with the NGO-led care group model, you have animators who are NGO staff. They supervise promoters who are often paid. And then those promoters each serve about 5 to 9 groups of care groups, which is groups of volunteers, and then each of those serve about 10 to 12 households. In the Ministry of Health-led care group model, you have a district health team, and one of the people on that team will then, of course, is supervising like the health center staff. Someone in the health center is chosen to basically work with the community health workers, and each of those community health workers works with about 1 to 3 groups of volunteers, care group or nurturing care group volunteers. And then each of those volunteers works with about 10 to 15 households. So the main difference is the community health worker, when they play that NCG promoter role, they're only supervising 1, 2, or 3 groups, not 5 to 9, which allows them to have a lot more time for all of their other duties. And we'll tell you a little bit more about how the results of using that Ministry of Health-led care group model a bit later. And in Ghana, we are testing the Nurturing Care Group core project model using both paid World Vision promoters and Ministry of Health community health workers serving as NCG promoters. So what happens during these care group or nurturing care group meetings? The way training is done is part of this project model. It's similar to what we call drip irrigation in agriculture. That is just giving a little bit at a time through regular 2-hour meetings every 2 weeks, instead of a week-long training, which can be overwhelming to volunteers, especially when they're illiterate. In this way, volunteers get over 100 hours of behavior change training in a year, about 2 hours, about every other week. You can cover a lot of behaviors with that amount of time and promote a lot of behaviors with that amount of time. During these bi-weekly care group meetings, a care group promoter, who can be a Ministry of Health community health worker, as I said, meets with the care group volunteers. The volunteers report on things like their progress and challenges in promoting behaviors. The care group promoter demonstrates this week's 2 to 3 behavior change messages using a flip chart. There's a group reflection on the messages. Then the volunteers practice behavior change promotion with flip chart and pairs. That gives the promoter a chance to give some feedback and coaching to each of the volunteers as they're doing that. And then there are other evidence-based behavior change activities in the lesson plan, like helping people to brainstorm on overcoming barriers and making commitments to changes. And a mix of songs, dramas, and games are often used. So what happens after care group meetings or nurturing care group meetings? After this bi-weekly meeting with the promoter, each care group volunteer meets with her neighbor circle or neighbor group. You can use either name. And that is a group of caregivers from about 12 surrounding households. And then she promotes behaviors using a small flip chart. Meetings are at the neighborhood level, not the community level, which helps increase coverage and makes it easier for mothers to attend. Contact between the volunteer and each household is done through a combination of these neighbor circle group meetings or individual home visits. And women who do not come to the group meeting, when that is a form of contact, if they don't show up to the group meeting, they get a home visit regardless. Most vulnerable families also receive additional attention, as do parents with a newborn child. One option with this program model is to do outreach to fathers and grandmothers through separate groups or during the home visit. The care group promoter directly supervises the behavior change promotion done by one of the care group volunteers in the group every 2 weeks. So not all of them, they're just too many, but every time they have a meeting, the promoter will go out, who can be a community health worker, and supervise and observe that nurturing care group volunteer doing her work. And the full cycle of behavior change lessons are usually repeated after about 18 to 24 months. So here are some of the nurturing care group modules and lesson plans. I'll point out the ones in blue. So for WASH, we have you can use up to 15 lessons that are taught over about 8 months. The generic lessons for that have already been developed for Ghana, and field offices can use those along with the flip chart images to create their own lesson plans and flip chart images. So they can either make small changes if it's what is in there is already appropriate for their context, or if they need to adapt it a bit. For example, for use in Asia, they would want to probably use other pictures. They would come up with those pictures themselves or contract going through TSO to get some of those pictures made. For health and nutrition, up to 17 lessons are taught over about 9 months. Those lessons are currently in development and should be ready by the end of September. And then we have, in education, you can teach up to 12 lessons, child protection up to 14 lessons. Those are also in development and should be ready by the end of September. There's an introductory lesson. Those should be done. The 5 lessons for the introduction should be used, which goes over WBI safeguarding standards per the recent guidance document, and things like what is a nurturing care group, what is a nurturing care group volunteer, how do you teach caregivers. So some of that is included in those introductory lessons. While livelihoods will not be a focus of this core project model, lessons can be promoted on this topic using the model, and they have been taught by other organizations such as Food for the Hungry. On faith and development, discussions are underway as to the type and number of lessons that will be included in the standard curricula, but field offices can also create their own. Gender is integrated into each of the sectoral lessons and included in introductory lessons as well. Let's talk some about the evidence. And as I mentioned, this is something, if you've heard this before, feel free to skip forward a bit to the next section. Here's one of the first studies on the care group approach that appeared in the peer-reviewed literature. This project was designed by World Relief in Gaza Province, Mozambique, and a mortality study was done as part of that in this project, which showed a 49% decrease in the under 5 mortality rate during a period of less than 4 years. This study in the Journal of Global Health Science and Practice was from a care group project done by Food for the Hungry that Adunia and I designed that reached a population of 1.1 million people. And in that project, we saw an overall 38% reduction in malnutrition, underweight, over the life of the project, which was about 4.5 years of implementation, and about a 30% reduction in child death. You may remember that earlier slide showing the results of projects using the caregiver approach to those that did not. That analysis was done in about 2010, but 5 years later in 2015, Christine Marie George, Henry Perry, who's part of our workshop this week, myself and others did a more formal study to verify if this pattern was real, looking at changes in 15 WASH, health, and nutrition indicators. We compared 10 care group and 9 non-care group projects in 5 African and Asian countries with approximately the same budget, the same project length, and that were completed during the same time period. And we found with that projects using the care group approach had doubled the behavior change of non-care group projects, and that they also had 53% greater estimated under 5 mortality reduction as a result of that. That last part about the under 5 mortality reduction was not quite significant with a p-value of 0.09, but the other finding about doubling the behavior change was highly statistically significant. This was when the approach was used for health, nutrition, and WASH behaviors, but there was no reason to believe that we wouldn't be successful in other areas like education and child protection either. Then in this 2015 peer-reviewed paper, we summarized the results of 8 projects using the care group approach and found that projects using care groups decreased child deaths on average by about 32%, as compared with only 11% reduction in areas where child survival projects were not using the care group approach. Note that Sarah Borger, one of the co-authors, was the lead author of our Nurturing Care Group training guide and led on development of the WASH and 6 CP behaviors that we are promoting in Ghana right now with Nurturing Care Groups. And I believe she is also involved with the other lesson plans, for example, in education, reviewing those. There are a few studies online of World Vision's use of the care group approach. This graph shows in nutrition indicators from 2015 to 2017 in a care group project conducted by World Vision Uganda. Note that there was a 32% reduction in stunting associated with these changes. Diane Bake, also in the TSO, published a study looking at prevention of moderate acute malnutrition and rehabilitation of underweight children, and concluded that both care groups and PD hard were effective in improving the knowledge and changing behaviors of caregivers, albeit the population reach would be different with the 2 models. There were more behaviors changed with the care groups, and Diane concluded that the 2 models should be implemented together, which is what Adunia and I also did in that large care group project in Mozambique. This study is on PCI's results using a model called Education Cascade Groups, which Cindy Fitzenmeyer and I designed. And there's emerging evidence that the care group approach can lead to significant improvements in early child development and milestone acquisition. So Cindy and I helped PCI to develop a variant of the care group approach focused on the nurturing care framework that was called Education Cascade Groups. And in that application of the care group approach, milestone assessments showed improvement in children in just 4 months, increasing the proportion of children who were advanced in their milestone attainment from 31 to 63%, along with a drop from 47 to 22%, and the proportion of children who were not doing well on milestone attainment. The Nurturing Care Group lessons for education are being built from the Go Baby Go model, which has its own evidence base, of course. And we are gathering evidence on the effectiveness of the approach on child protection behaviors as well, but we expect to see similar results. This approach has also been used in very successful malaria projects. For example, these are the results of a World Relief Care Group project that trained 2,315 care group volunteers on malaria prevention and care seeking that reached 23,500 households. And among the results that they saw were an increase in ITN usage from 1% to 85%, an increase in care seeking for fever, suspected malaria, from 28% to 90%, and a reduction in the incidence of fever from 50% to 6.6% in only 4 years. And then note that most of these increases were achieved by midterm, within 2 years, and that's not unusual in projects using the care group approach. This model has also been used in TB control. Anthony Aburra on our Global Fund team was involved with some of that work, where the treatment success rate rose from 79% to 93%. Let's talk now about the extent of rollout and the cadres and different types of community health workers implementing this model. So the care group approach, there are projects usually utilizing paid NGO promoters and possibly community health workers as well, and at least 12 of our field offices shown here. There are also care group approach projects utilizing volunteer community health workers as nurturing care group promoters, and at least 4 of our field offices, Ghana, Kenya, Myanmar, and Tanzania. Let's talk some about the successes with using this model. One of the successes is that a lot of organizations have scaled out this model, both across countries and regions and across organizations. The care group approach has now been used in over 30 countries by more than 30 organizations, and this slide shows many of those. I think the uptake of the model speaks a lot about how easy the model is to use in many different contexts, and the evidence base, which is one of the principal reasons that it has spread so far. World Vision staff have been involved in introducing this model to new countries and regions as well. For example, Adunia in Malawi, and myself in Guatemala and Haiti. And the model is also being used by some national governments, especially in Malawi, but I was told last October that Uganda is considering using it for national scale-up as well. Concern Worldwide did operations research comparing that MOH-led to the NGO-led version of care groups in Burundi, and found that from the very beginning, shifting the management of care groups from NGO staff, that is paid promoters, to Ministry of Health staff using community health workers in the care group promoter role did not lead to a deterioration of the results that were seen. Note that the Ministry of Health-led integrated care group model achieved similar health and nutrition outcomes and functioned as well as the NGO-led model, suggesting that the MOH can implement and manage care groups on par with NGOs. And I have the link to that study there. Another success of the care group project model is its sustainability, especially in terms of the gains you can get through this approach. This slide is from a World Relief project using the care group approach in Mozambique, and shows that for this indicator, children receiving organ rehydration serum during diarrhea, World Relief saw an increase from about 47% to 82% during the project, which is a nice increase. But notice how it increased further to 100% of caregivers that were sampled at 42 months after the project. This is 42 months after the project ended. So the blue bar shows when the project ended. They ceased operations. They came back at about 30 and then 42 months later to see what had happened in terms of their project indicators, and they saw an increase there. Results, in fact, were sustained or improved upon at 30 months and 42 months post-project on about 17 indicators. Here are 8 more of those. Feel free to pause if you want to read about these. Sorry, some of them at the bottom are in Portuguese, but that's children who receive more food after during diarrhea, and women who use family planning, a modern form of family planning. Another care group sustainability study was conducted by Tura et al. In 2015, 5 years after the care group project that Adunia and I worked on concluded in Sofala province, Mozambique. And that study found that large care group project, 61% of participants said they were still receiving biweekly care group volunteer visits 5 years after the project had closed. For 77% of the indicators assessed, statistically significant program gains were sustained 5 years after the close of the project, and underweight fell an additional 12% in the 5 years following the project close. This isn't really a success, but one of the advantages of this model and using it in World Vision is its low cost per beneficiary, especially when we're thinking about what's affordable with child sponsorship funded APs. We did a costing exercise in Ghana of the Nurturing Care Group project model and a more general one for Africa earlier, and found that the project model would cost about $2 per beneficiary per year when reaching 0 to 18-year-olds, and when reaching 0 to 5, the cost would be closer to about $4 to $6 per year. In comparison, here are costs per beneficiary of some of our other project models and core project models, which are quite a bit more expensive. Of course, if you want to address something such as acute malnutrition, this should be no reason that you wouldn't use CMAM, but you could use it in addition to a model like the Nurturing Care Group model to do general behavior promotion for health and nutrition. In terms of the challenges, one is that Nurturing Care Groups are a new core project model for us. Some fields may have experience with care groups and should have little trouble using care groups more broadly to promote other sectoral behaviors with nurturing care groups, but there may be some reluctance in using any new model. And nurturing care groups are multi-sectoral, which confuses people a bit since our systems are not always that multi-sectoral friendly, even though we want to expand our integrated multi-sectoral work. Those of us who have helped multiple organizations to adopt the model have heard it countless times as well. People won't work here as volunteers. You've got to pay them, only later to be proven wrong. But the care group criteria need to be followed to avoid having the volunteers working more than 8 hours a week. And attention does need to be given to those non-financial incentives like public recognition of the volunteers, giving them identifiers like badges or T-shirts or a wraparound skirt so that they can be recognized for the volunteer work that they're doing. When a field office wants to focus only on promoting health, nutrition, and WASH behaviors, we are asking them not to say that they're using nurturing care groups, but just care groups. So care groups can be a service option as part of the CHW core project model. But we should expect some confusion around that with field offices not always being sure how to put together the TP. Is it care groups as a service package of the CHW core project model? Is it the Nurturing Care Group core project model with health and nutrition being the leading sector? So we'll need to provide some guidance on that, but it might still be a bit confusing for some fields. Also, sometimes it takes some trial and error to get the structure right. How many care group and Nurturing Care Group volunteers per care group, how many caregivers per nurturing neighborhood group, and the balance of the group meetings and home visits. I've also reminded people that the care group approach is a bit relentless. They require continuous training by the community health workers to volunteers every 2 weeks, or from the paid NCG promoters to volunteers, depending on the configuration. So it's more continuous and less episodic than some of our models. Once you set up this structure, it doesn't make sense to roll out a new lesson every 2 weeks, to stop rolling out those lessons every 2 weeks. And in fragile context, it may require a bit of starting and stopping when there is conflict, insecurity, epidemics, etc. There's also a lot of printing required, since you're printing flip charts often for thousands of volunteers. Note, this is built into the cost per beneficiary. It's still very cheap in terms of coverage, but it's a lot of printing. Another challenge is that it often takes 2 to 4 months to set up the structure for nurturing care groups or care groups before you start doing behavior promotion. That's one of the hardest parts of using the model, as it takes a lot of community organization. However, once that structure is set up, it's not that difficult to use. And this will probably make it less attractive for very short projects, and field offices should really be encouraged to have other sectors use the NCG structure after a particular sector is done using it. So even if they start using it for health and nutrition, after that they might say, hey, let's see if child protection would like to use this to teach all the child protection lessons. Here's some recommendations for World Vision support. One is that we recommend flexibility in staffing. I would suggest mostly using paid World Vision care group or nurturing care group promoters the first time that they use this approach or model, but increasingly moving to do it through community health workers who serve as the NCG promoters. You could do it like in Ghana, where most are NCG promoters paid by the organization starting out, and then you also train some community health workers to teach the volunteers, or you might just decide to at first just have paid promoters and then transition after you get the hang of the model to working exclusively through community health workers, which will really bring down cost as well. In terms of supervision, it can be done by staff without a health and nutrition background if needed, giving the non-clinical behavior change focus of the work. Some other considerations: staff guidance is needed to carefully avoid overlap with other NGOs and World Vision models. You need to promote complementarity and task shifting from overworked community health workers to care group and nurturing care group volunteers. And this information is included in the training manual. You should also promote use of health and nutrition lessons through nurturing care groups, even where other sectors are leading, and have some reciprocity where we'll be asking child protection, education, and WASH, when they're using nurturing care groups, of, hey, remember we have some important health and nutrition behaviors that we would love you to promote as well in these areas, even if that's not the sector that is actually taking the lead. We have a ton of tools for use with care groups and nurturing care groups that are shown here with some links. I look forward to your comments on ideas on how to integrate care groups into the community health worker core project model as one of several service packages. Thank you very much.